Yes.
This meeting is being recorded.
Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. Um, Is anybody participating virtually? No, we're all here. Great. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on March 11th, 2024. I'll poll each member for their vote. Jose?
Yes.
Dr. Katz?
Yes.
Sally? And Barbara? And I vote yes, so the motion is adopted. And today we have one agenda item, which is the financial update, so we can finally get a full update from the team today. So I'll turn it over to John.
Good morning, and thank you for your time. So yeah, we have a report. We're at the 3-quarter mark in our fiscal year, and I would say the system, I think, is performing, very well, even despite the disturbances of, the change disruption that we talked about last time. We closed March with $708 million, or 26 days cash on hand. And then when we took the snapshot of how we're doing against the budget in February, again, this is before the effects of the change disruption, we were running about 1% or $156 million ahead of the budget. So that was, I think, pretty good. Right? There's a lot of movement, which we'll go through within that number. But we feel pretty good about that. We're also starting, Margie will go through this. We are seeing, post the disruption and the moving to Experian that, cash is coming back into the system. So we feel that we should close the year strong. But we'll go through, some of the issues that may be before us there. I think one really good measure, and we do have that chart, back in the deck, is that we're reported in terms of actuals that the system for direct patient care receipts is running $325 million higher than the same period last year. So that's always a really good sign. That's an actuals to actuals measure. We're seeing, volume, continues, to come back post-COVID, running 1.5% ahead on the inpatient side, and outpatient visits 9.3% versus pre-COVID. Those are all very solid numbers. And strategic financial initiatives through the end of the third quarter, we've recorded almost $25 million versus our target for the year of $1 billion. So we're very confident that we'll finish the year. We're even having discussions about raising the bar, right? There's a realization amongst our group that the foundation is set, right, to even, generate, additional savings. So we'll talk about that when we have the FY25 budget, in place. But really, from where we are now, all pretty good news at this point. On the next slide, we're forecasting that we'll close April at $600 million, and then in May, $600 million. Those are our estimates at this point. So again, we're starting to see the return of cash. That's pretty much in line to where we thought we would be at this point, prior to the problem with change. In terms of managing risks, we're slowly turning green. Many of these measures that we've been watching closely because of the effects that could have on the financial plan are really actually improving. I talked a little bit about change, and Margie will talk more about that, but the new system for the most part is in place. Medicaid recert, I think we set the target at around 79-80% recert rate. We're doing better than that. Certainly helped with our partners at Health First, Metro Plus as well. We're confident that we'll beat the budget on the Medicaid recert, even though more work to be done there, and we have a chart on that as well. The city-state budget, again, we think certainly not harmed. We have a chart we'll go through on the state budget that's becoming a little clearer to us, but that we think the city-state budget will actually have a positive tailwind for us. So, but we'll keep an eye on that. We've managed the pegs that were asked of us, so those are all in the plan, and we could absorb that. Inflationary pressures, right? It's just affecting the economy overall. and some would say particularly in healthcare. So we continue to, watch those expenses, particularly in pharmacy and med surge. We'll have plans in the budget, going forward to, curtail those increases as best we can, through a combination of better pricing and utilization. Mitch has asked us to, use less paper. I've switched over to my little yellow pad that I use now. I've tried to slow that down. But the little things do count here, and I think that is Mitch's point, right? And certainly, again, when we talk about where we think there's room to raise the bar, we think, controlling our costs in that area where we can and utilization will help. And then the glide path, again, I think maybe this is the one most proud of is, we had a pretty significant problem this time last year as it related to, contract nurses, and we have the NISNA contract in place. They've been excellent partners with us, and we're making substantial improvements across the system in terms of converting our nurses to H&H nurses. So very proud of that effort. Natalia did a fabulous job. She's, meeting with the facilities, constantly to try to make sure that we're are aggressively out there trying to attract nurses to health and hospitals, and that's all very good news. We're still working through the affiliate spending. We did put additional resources into the budget related to the affiliate spend, but we're undergoing a pretty detailed process in terms of setting the budget for FY25, almost a line-by-line accounting of the positions that the facilities need. And as part of that, we're really focused on trying to reduce sessional spending where appropriate. I think what that mostly entails is hiring, doctors to replace the overtime hours. So I think that's what will come back, from the facility. And then on locums, same situation. We just need to attract our own physicians to work at health and hospitals. So that's our risk situation. Again, I think I think we're improving. The inflationary pressure one might be the most difficult one to try to get a handle on for this year. Any questions there? The budget. So again, we wrapped up the budget. Was it last week? Our early view of the budget is that it's probably on balance neutral. Could be positive for us, depending on a better understanding on how certain items shake out. There's hospital and nursing home Medicaid rate increases. I think in total that's about $525 million gross, but we're not quite sure exactly how those dollars are going to be allocated. So I think we have some work there to better understand what the drafters of the budget were thinking of there. There's like $75 million in the budget for primary care, which is always a good place to invest money. Essential plan and Medicaid coverage provisions. There's some enhancements there. Safety net transformation, it's referred to as Part S in some cases, is really pretty innovative thinking. I think it's approximately $300 million of state funds, where they're trying to encourage safety net hospitals, to partner with either other safety net hospitals or other providers, right, where there are synergies, right, that they want to explore, either in terms of better clinical care or financial savings. It's sometimes hard for independent, safety net hospitals, to find those scale efficiencies. So that's interesting. We're glad to, see that in the budget, and obviously we're always try to be helpful to our safety net partners in terms of delivering better care and finding those synergies. There's more money in the budget for behavioral health. There's a COLA, loan forgiveness, things that recruitment, which is always a real big issue in behavioral health. So we were pleased to see that. There's some workforce proposals in the budget, maybe not as far as we'd like, but again, we're taking a look at it. And then the last one is an interesting one. During the budget negotiation process, the Assembly put an idea of an HMO tax on the table. It was reported to have savings or revenue estimates of over $2 billion. That's obviously a very big initiative. Our view of it is that, an HMO tax is allowable, and there's taxes that really make the the healthcare system work in New York that are aimed at hospitals and nursing homes and other providers. So it is a quote, a taxable class. But there's a lot of very important details, that go into that. There's a lot. Certainly, when you make the tax what they call Medicaid reimbursable. So, if it, the way we understand the discussions and the framing of this is that for purposes of Medicaid or those plans that do a lot of Medicaid business, like Health First and Metro Plus, the tax will in essence be reimbursable and be included in the premium. But again, a very inventive, creative thinking there. I think they made the right move. It's a very large sum of money. They have to negotiate it with CMS. So they established this healthcare stability fund, again, and within the statute authorization to pursue the tax. So this will really be setting it up for next year's budget. On the negative side, very disappointed to see reductions yet again in the managed care quality pools. I think the total count, at least on the Medicaid side, is that the quality pool is only a little bit more than $50 million. At one point, it was maybe $350 or $400 million. So it continues to be, cuts made on the quality pool. We value the quality pool. We like to make our margin, as we say, by providing, better quality care. So hopefully with this HMO tax, if that does come, to fruition, there'll be a restoration made to the managed care quality pool. There was an increase on the essential plan quality pool. I think maybe the drafters thought that would, help counteract the Medicaid quality pool cut, but again, I'm not sure if that's the best way to look at it. There's a lot of people served that are on Medicaid that aren't in the essential plan, and but again, hopefully we can fix that going forward. Again, also disappointed there's a second 10% capital reimbursement cut. I mean, those cuts really hurt safety net providers, that struggle with having adequate capital infrastructure. Nonetheless, that was in the final budget. And the last was a 1%, across the board cut to health plans. But, again, we're adding it all up, but we feel, again, we'll be okay here. And we are certainly, as always, committed to, helping the state make this a successful budget for them and us.
John, what do you think for the 1% across the board cut to health plans? Do you think that's based on the state looking at their balance sheets?
Yes. Yeah, I think if I had to look at all those cuts, they were just trying to get, to a target.
They're trying to get, but I mean, they're adding and they're subtracting, so they needed to also add stuff. I'm just wondering whether there is, for example, like on the Medicare Advantage, which is not what this is, right? There is some data to suggest that plans really have been taking unfair profit.
Yeah.
Right. And I'm just wondering, is the 1% in your view based on them reviewing sort of the balance sheets of plans and feeling like this is doable, or is it just we got to close the gap somewhere and people hate plans, so go ahead and do it there?
Yeah, no, I think it's probably a combination of trying to hit the budget target. In the old job, you would always you'd pay attention to that point is how much profit is being made, right? So that are you setting the rate right? And I think but at the end of the day, the state still has to set a rate that's reasonable, right, and fits within the bounds that would be accepted, by CMS. I know at one point they were trying to get, to the 25 or 50% of the range, closer to the 25% of the range, and with this cut, that will come back down. But I just, it's all of those combination of things. For us, it's a direct. It becomes a direct cut, because of our relationship
Sure.
with Health First and Metro Plus. It's not a cut, right, to most other plans, where we don't engage in capitation arrangements. But that is a direct.
And does it affect every single line of plan's business, or just certain lines of a plan's business?
It's just really a one. They set the premium and they cut it 1%. So you know, it's the total premium would just be reduced from where they would set it by 1%. It'll still be, you know, a year-to-year increase, right? Because they have to factor in, you know, inflation, utilization increases. Those are all part of the rate setting process, but they'll take a reduction of 1% as part of that process. Yeah, we don't like it.
I'm just curious, sort of what, interesting to me what they choose to cut and not cut.
Yes, yes. But I think a real improvement from the executive budget to where they landed in the final budget. The executive budget had many, you know, deep cuts that were, in essence, quote, bought back. But next year will be interesting with the HMO tax. We'll see how that, we'll watch that carefully. Yeah. Any other
I
questions?
just curious about the focus on the essential plan, doing quality pools more for essential plan and reducing for Medicaid. There seems to be a real focus on the essential plan, increasing the income level eligibility. I saw one article talking about QHP, people falling out of QHP into essential plan.
Yes. Yeah, those, and we have a slide on that. We'll talk about that. I think, you know, you asked the question, why would you cut? Again, it gets back to Mitch's point about, you know, the budget and trying to hit certain targets. You know, the essential plan is 100% federal funded, right? So they will go there first, right, to try to, you know, maximize those federal dollars, and that's more than likely why they increased the quality pool there, but cut it on the Medicaid side, right? But again, it's always important to, you know, try to maintain parity where you can, because the incentive structure will have an effect, and everybody knows the essential plan is a pretty rich plan at this point. The rates are set, you know, very, you know, desirable level compared to Medicaid, but you gotta always be mindful of keeping that balance, because it will drive incentives that perhaps you don't want to create. So,
Thank you.
I have. Now, when it comes to prison health, it looked like there's a movement occurring to go further north.
I'm sorry, with
Prison health.
Prison health.
prison health.
Yeah, prison health.
Yeah,
It seems like there's a movement to move more of that work effort north.
north. I'm not familiar with.
I thought I heard that.
It could be for, you mean like upstate?
Yeah.
Yeah,
Yeah,
less expensive.
yeah,
Workforce less expensive upstate.
We lose a little bit then.
Yeah.
and space, right? I think there's space there probably too. But we are working with Patsy on an initiative to kind of repatriate or keep certain folks that have behavioral health problems issues at Elmhurst, right? They would otherwise go to a
Right,
state.
but she's talking about prison,
Okay, yeah,
that's jail.
yeah, yeah.
Yeah.
Okay,
But if there's a trend there too, it's
Yeah.
good to put it on the table. Yeah, thank you.
very good. Okay,
And so for our financial performance, we're gonna go through February, as John spoke to it earlier. This is ahead of the Change Healthcare impact on our dollars and margins. Through February, we are at 1%. Our receipts still continue to be ahead of budget. We have there about 464 million. You'll see the components of it later. They stay pretty consistent with what you have seen in the past reviews of the data. And the risk is we're getting risk dollars that continue to be higher than budget. We spoke about the prior year reconciliations piece, but also our improved PMPM is still strong there, and the improvements are still ahead of budget. Our patient care is also higher than planned. And then you'll see also the impact of the financials on our disbursements and the spend on the expense side being ahead of budget by about 308 million. The components are some of the components we spoke about in the area of managing risks. So our temp coverage, but we are anticipating to see major improvements there financially, as John spoke specifically to the nursing piece. As we offboard more of those temps, we're gonna start to see more of the larger financial impact trailing after that. then we have our affiliation impact, then we have our spend on OTPS, which is where you see the inflationary impact, and then the overtime costs, which we're looking to assess basically which areas that we are seeing more of those things, like in areas of facilities or EVS, which are critical and essential for us, definitely to maintain our facilities upkeep and housekeeping and all these components. But we're going to be assessing that particularly as we plan for our fiscal '25 budget and see where we need maybe additional staff, or where we still need to keep some level of flexibility of that overtime, which is essential when we have urgencies at our sites. So there'll be more on that, particularly in the next budget plan. And Tasha will take us through the components of the revenue expense.
Thanks, Michelle. Okay, so to dive deeper into the revenue variances, our cash receipts are 9% of the budget, and most of that is coming in or attributed to prison revenue, as Micheline noted before, but patient care receipts are doing well. We see that there's 2% improvement in our inpatient discharges, and on the outpatient, our volume rates, professional billing, prior year appeals and settlements, and cash performance is all coming in better than we anticipated. The risk pool, there is a level of timing associated with the performance that we're seeing. About 30% of the variance is due to unbudgeted collections, or collections due to prior year reconciliation. And we also have better PMPM coming in this year than we anticipated in the budget. Other revenue that are exceeding the target include miscellaneous revenue related to community pharmacy, or formerly retail pharmacy, interest payments, and other administrative collections. So at the bottom, you see the breakdown of the overall $453 million that's coming in better than budget. On the expense side, we're also over budget by 5%, driven primarily by temp and agency spending, as Michelle noted. And we do have a collaborative system-wide effort, which includes finance, HR, nursing, on the full-time recruitment and retention of H&H and affiliate staff, in alignment with our models, and to support clinical services and overall volume increases. And the plan is, as hiring increases or ramps up, the need for temps will go down, and we'll start to see the spending go down as well. On the PS side, we're looking at overtime, as Micheline noted prior, looking at our models, perhaps developing one for overtime. And on the discretionary spending, we're over by about $100 million due to pharmaceuticals and medical surgical supplies. This is due to increases in volume and also in prices for inflation. And that's the breakdown there.
Do you have a breakdown of what's inflation and what's due to higher volume for the?
Right, so volume, we're seeing about 40%, and then the balance is inflation.
Okay.
But we do have some analysis for each separately on pharmaceuticals and medical supplies, and hopefully some of the savings that we realize in temps perhaps can cover some of that savings, or some of the spending on that side.
Right. And the temps, the $130 million, even though I think on the glide path we're ahead of schedule, right? But the dollars are not being realized yet.
Right,
Is that-
because basically there's a lag between offboarding the temp, and then you start to see the annualized fiscals follow. So it's not immediate, right? And most of the reductions have been after the settlement of the NISNA contract in August. So it takes a lag of hiring first our full-time staff, or putting them through orientation properly for safe transition, to transition the temps off. So there is a lag by the point of the temps transition off. So most of the progress we have seen has actually been in this last couple of months, literally, or that last quarter.
Right.
And so that's on the offloading of the actual staff, the temp staff, and then you start to see the financial savings come after that, as you know, now you're reducing it post them leaving. Does that make sense?
So I guess when we're kind of projecting out for the
Exactly.
next budget, or we want to think about that time, because this is a pretty big swing, right? $175 million from what we,
Exactly.
even though our timing is on track or ahead of schedule,
Ahead of
the
schedule,
dollars are not.
So you're, right, so you don't see the larger dollars immediately, but you will see larger financial gain in fiscal '25.
Right, so that'll ripple through. But
And
Now,
we're pretty
what-
confident that it's, I'm sorry.
Go ahead.
No, I'm just gonna say, we're very, I think our confidence is high that the savings will in fact materialize because Natalia and her team actually almost on a contract nurse by contract nurse basis knows when they're going to depart, right? She knows who's been hired, she knows where they are in
Right.
the training, path. So she knows who needs to exit, and that process is underway.
Right, on the individual level by facility, she's meeting with facilities
Nice.
weekly. It's really a great effort that's been going through.
I think there are some common factors that we can expect this time of year. New grads, they run to us for orientation, and then they have a plan to move out of New York or do whatever, go somewhere else. And it's always that way.
Yeah.
But we've done phenomenally much better than we've done for years.
Absolutely. It's
Thank you.
really, the progress is evident in our hiring, so it's been really great. Yeah.
And when I go to the facility, I love seeing the faces. Everyone is happy.
Important, yes, that's great.
I think it's a great point because it does give us a chance to kind of, change the culture, right?
Right.
With that many new nurses, and Natalia's done a great job.
We've done
with
that
the
for
training
sure.
program, and so and on the way out the door, we're recruiting the contract nurse as they go, right? We'll tell them, we've enjoyed having you. We have a job for you if you so choose. But
Yeah.
so I think things are moving well there.
I think, I mean, just, we're 1% ahead of budget. I think that's great. I mean, that doesn't reflect some of the change healthcare stuff, but we'll hear that that's coming along, right? And from your cash forecast, it looks like we think we are going to recover from that. The one thing I note, though, is that some of the variances, we're fortunate that we have high variances on the revenue side because it's offsetting the high variances we're seeing on the expense side. So one question I wanted to ask about is the risk pool. 79% is better than expected per member PMPM performance. That we can't anticipate necessarily, is that right? We can't.
The ones where you have the reconciliation for prior year is the one that's kind of the one time,
Mhm.
And the PM improvement will be doing more.
We'll be
this
able
is
to
in
see
terms of
that.
continuity, but there's definitely a chunk of that we
The 26%.
Right.
Right. And I think you guys are gonna maybe hit on this on the risk pool, that might start to change, is that right? Yeah, okay, and so that's factored into our budgeting for going forward and looking at that. Okay, well, I'll wait till we get there then. Thank you.
Okay, and this is a few of our year-over-year performance, revenue or receipts that have come in through, last year at this time. We are $325 million higher than FY '23, and some of that is attributed to approved state Medicaid increases, federal approved billing UPL, and overall increase in volume and cash performance. And through the same time last year, some stats include the discharges are up by 2.7%, outpatient visits are up by 4.8%, and the case mix index is slightly higher by 0.5%, looking at the same time last year. So we're doing, and the breakdown below shows the buckets between the different areas.
We like the purple bar chart. Glad we got to talk about it. Yes.
Okay, you can move to the next slide. So first we'll talk about Medicaid recertification, and I'm happy to report that the recertification rates remain in line with our budgeted, anticipated financial plan, just about 2/3 of the way through the first year of recertification. Through February, Health and Hospitals is averaging a 79% recertification rate for a combined MetroPlus and Health First, which is the bulk of our membership. And that's ahead of the financial plan and just shy of what we had as an internal stretch goal. We're showing, pretty solid performance through March. March is kind of grayed out there because it's not yet complete and doesn't doesn't complete until the end of April. This is reported through mid-April. In December, I just want to point out, I think we've talked about this before, but there was a very high recertification rate for Health First. And it was driven by some automatic extensions of the HRA, which is the disability population, and they terminate through the end, they're automatically recertified at the end of the year. Any questions about this? Okay. Moving on to the promised conversation about Change Healthcare. John alluded to, we're continuing to make progress in recovering from what was the Change Healthcare cyber attack. Change Healthcare is our vendor, is our clearinghouse vendor for claims eligibility and electronic remittances. They experienced a cyber attack on February the 21st, which pretty much stopped all of our ability to do any automated eligibility checks on our upcoming patients, as well as our ability to send claims or receive remittances. The board had already approved, prior to the cyber attack, a new contract with Experian, which we had anticipated implementing July 1st. We were able to leverage that contract and accelerate the implementation, first prioritizing getting claims out the door. Our claims are now live and caught up. So between April 1st and April 16th, we sent out close to 400,000 claims to catch up on all of the backlog. And we are now live and caught up with the exception of dental claims. And we are working fast and furiously to be able to get those claims out. They're highly specialized and difficult to program, so we prioritized everything else. Eligibility was next up. We are live with batch eligibility, which sends batches of our claims out to the payers to automatically validate and get the responses back. We don't have every bell and whistle implemented, but we're continuing to optimize. We are not yet live on real-time eligibility, which is our ability as we're scheduling a patient or a patient is registering at the point of service to do kind of a real-time ping out to a payer and get a response back right then and there. We are not live with real-time eligibility, and the expectation is that we'll be live June 1st. Our biggest sort of quagmire has been with remittance files. We are seeing payments recover, so we see the cash in the bank. As we got caught up with claims, starting in probably mid-April, we started seeing the payments come through, which is great in the bank, but unfortunately we are not live on remittance files, which post those payments back to the patient accounting system for all payers. We are live with some, and to be fully live, we expect to be live on Experian by June 1st. That doesn't mean we'll necessarily be live with all payers, and we are just continuing to push the payers that have not reconnected to Change Healthcare to figure out what makes the most sense for us. While, in general, this is a good news situation, on the payment side, what it is continuing to perpetuate our backlogs on the operations side in terms of handling secondary claims and denials in any kind of, we're just creating backlogs for ourselves and trying to point the patient accounts and patient access folks to the most important things, prioritize what they're working on.
So how do you think this is going to show up in our financials?
Yeah, no, I think really to kind of complete, the recovery plan, right? Remember we talked about a 3-phase recovery plan, each one being 6 weeks, starting with, we had balances, fortunate that we had cash balances available. So that carried us for the, first 6 weeks. The second 6 weeks, James working with, our city partners, right, to move money back and forth. Again, all part of just usual business. The final, right, phase, right, I think will hinge on, how do we do with the denials, right? We're asking our insurance partners to be flexible with us in terms of, the processing of denials and opening the window from which we can process denials, and I think we're making progress there. And with the state, we do a lot of business, Medicaid fee-for-service business, so having them be good partners with us in terms of how they treat the denials and allow us to appeal denials will be important. But again, we've asked them to really just in essence follow the guidelines set out by the Department of Financial Services, right? So we don't anticipate that should be an issue. The other important part, right, this was phase 3, is dealing with our federal and state partners. We have 2 significant transactions, right, that we've had built into the plan for the year. The first is inpatient UPL. You've heard us talk about that. That was a transaction that was initially approved by CMS last year. They renewed that approval over 2 months ago now. Almost 3 months, right? It's been approved by CMS and sitting with the state. So we understand now that the status of that package has moved from the health department over to the budget division. That's the last step. But again, time is of the essence there because to effectuate that transaction takes at least 6 to 7 weeks because there's other things that we have to do in terms of moving the money between us and the state and then from the plans back to us. But we're well versed at that.
But is that tied to getting live on? No. So that's okay.
No, it's not. It's just part of our plan. This is to get us
Right.
over the finish.
Got it.
Yeah. Yeah.
For the delays that this is causing, basically.
Yeah.
Right.
So, and again, we have a number of options on how things could play out, right? We get all the way back online with Experian, right? We get back up to speed on denials, process those.
Yeah.
That'd be fine. And the last transaction is outpatient UPL, right,
Yeah.
which is new to CMS.
Right.
We've not done that before. But as early as last week, they've communicated back to us that they're going to ask their final set of questions on that, which we think should not be too difficult for us to answer. So that's good news. I don't think the outpatient UPL package, that there's enough time to have that transact before we close the year. Right, but that'll be okay. If these other pieces fall into place, we'll be fine. In some ways, it's like no different than any other year.
Right, I was going to say, this is a conversation we have at the end of every year, but for different reasons.
Yeah, we're starting to look at the close a little bit sooner than we usually do, and James is kind of laying out different options for that. But I still believe we're going to be fine. We're going to be fine. It's just it's just timing.
John, going a little deeper into Frida's question, we've mostly focused on timing, right? Making sure we can pay our bills. But if we just put that aside for a second, at the end of the day, will we lose money because of this?
I don't know. There's a possibility, right, that we could lose money on the denial remittance part of the glitch here. But Bob's been looking at our cash, and it's pretty much. We say, I won't quote them, it was 94, 96% of where we should be with cash, right? Some of that is the denials, it will come back.
Right.
But we make our living, we say, in the last 1%, right? You can't, 1% makes a difference. That's the margin that we have here, right?
I mean, I would look at it, everything John said, it obviously is accurate. Just from a pure operational standpoint, if the payers don't all cooperate with the extensions, that's the possibility where we lose. If they cooperate, it's going to take us some time to dig out from under these. From the payers that we are getting the remit files, we are seeing, as expected, higher than typical denial rates for eligibility because our eligibility wasn't live. So we sent it to the payer that we had on file, not necessarily the right payer. And so we're scurrying and trying to address all of those in a priority manner. And then, we have the denials sort of laid out in priority order. If a payer comes back and said, well, you were too late to bill us because we did pass their timely filing and we couldn't post the remit file from 4 months ago, that's the danger. But we are labeling and categorizing everything to fight it down to the last dollar.
So there hasn't been any regulation or anything from, say, the federal government or to extend?
There was guidance.
Yeah.
So CMS gave their guidance as to what they were planning to do, but it's not regulation.
So payers have the option to not.
Yeah, but I would go a little bit further. DFS, state DFS, Department of Financial Services, that regulates the non-Medicaid insurers, you know, issued very direct guidance. um, and what we do is, you know, we keep track of who, in fact, is recognizing, you know, that we have issues and who's not. And I think the best that we can do is to inform them really on a claim by claim basis of what is kind of fallen, you know, within, you know, being classified as an impact related to change, right? And I think worked fairly successfully with, you know, even the state, where we've said, look, we have a file of claims that fit within the denial period that we want you to recognize, right? And again, and we even had to attest, right, to DFS. Matt Ziegler had to attest to DFS, right, that we in fact had these various issues that we were requesting that the insurers address. So I don't think it's over, right? I think it's not as big of an issue because I think just like us, we've moved quickly. Other providers have moved quickly to try to, you know, switch to another clearinghouse and put in other systems. But I don't think it plays itself all the way out for some period of time until you get to the end.
I think Sally is the only lawyer at the table. If we were to lose money because of insurers' unwillingness to go beyond the date, would we not have a legal claim against the change?
I think we'd have to get in line.
Yeah.
This is a company that like had a $300 billion profit last year. I mean, they're not going bankrupt.
Right.
No matter how many claims, they're not going bankrupt.
So OLA is looking at that as well. You know, we're, as I said, sort of ticking and tying and making sure we can put everything into an appropriate bucket. You know, all of our claims, all of our denials, and working through it, as well as any expenses that we've incurred because of this. And OLA is, you know, sort of looking at our options.
Did we have an interim vendor before Experian? Did we approve? I have some memory of
We
it.
didn't, so Change Healthcare was our vendor, and the board approved a transition from
Right.
Change Healthcare to Experian. We were just able to leverage that Experian contract to implement it earlier.
Right, so we didn't do an interim
We
one?
didn't. We didn't.
Okay.
We
Yeah,
just started sooner.
Yes.
And it was either, depending upon what you think, either brilliant judgment or we got very lucky that we had, you know, gotten this RFP and were able therefore to start it earlier.
It was
I think it was a
brilliance
combination of
and
both.
luck.
I
Yes,
think it was a
I think
combination
it
of both,
was brilliance
right?
and
And
luck.
both had
Most
to happen.
things are.
Right, yeah.
Luck favors the well-prepared.
Yes, it does.
Right.
Yes, yeah, both had to happen, right? And it is. I think it also raises the issue about just redundancy.
Yeah,
You know, do we need to have redundancy?
Right.
And I think once we put this behind us, we'll come back and answer that question for you. But
I guess Metro Plus tried to have the redundancy built in, and then companies kept getting swallowed up.
right.
So everyone they were using for redundancy was taken over.
And we've already started engaging in that conversation with IT.
Right.
So we'll see what their recommendation is.
Okay. Well, so from the timing standpoint, it sounds like you guys have some backup plans and backup plans. And the bigger question of are we actually out a loss is still.
we can report back.
You're doing as much as you can to prevent that, but obviously we have.
And we're keeping track of it, right? I
Right.
mean, we're you know, we're tagging each claim that
Yeah.
we feel, right, so.
Okay. Thank you. Any other questions for Margie? VPP? Yeah, thank you.
Great. Good morning. So this chart here is just showing that 2023 was a good year for us with our risk pool payments. I would say it was maybe the best year we've ever done. And I think that was a confluence of a lot of different things happening, mostly on the revenue side that, for example, there were retro increases to the Medicaid premium that was approved in last year's state budget. And increases to the essential plan premium, both of which are very large populations in our risk pools. I think that's the blue bar and the orange bar. So you can see that's the vast majority of our population. So as we get additional revenue, that helps our surplus if our expenditures stay relatively flat. So I think the risk for us going into fiscal year 25, starting in July, is that we do anticipate a much rougher year with our revenue. So I think part of it will be as we see the Medicaid recertification kind of begin to normalize, we're going to see some losses. You can even see it in the last blue bar that the Medicaid line is slightly going down. So I think with less volume, we're going to see lesser premium. A lot of the people that are being kicked off of Medicaid are ones that maybe were lower utilizers. And so that is a risk when you're looking at insurance, right? If you have higher cost populations that remain, that's going to eat into your margin. The other major element I would say is on the Health First side that we have a pretty large book of business on Medicare managed care members. And Health First unfortunately lost a significant amount of revenue for calendar year 2024 for not hitting 4 Medicare stars. And so we will definitely see an impact. We have budgeted for this going into fiscal year 25, but they're hoping to break even. So some of those surpluses that carried us in 2023, we don't think that we're going to see for calendar year 2024, which we will start to receive later in fiscal year 25. Any questions about this slide?
Is there any one population that we can look at a little further, maybe adolescents and peds?
Sure, we can definitely try to see what is changing with our pediatric population, what proportion. They should mostly be in the blue bar because kids don't qualify for essential plan. So we could try to quantify what proportion of that bar are kids.
And CHIP too, right?
CHIP is in.
Chip, yep.
Yeah, I'll just say, anybody who's been involved in measuring risk surplus has never seen the performance, right, that we saw this year, right? I mean,
This year.
John Bermel, the CFO, right, of Health First. I mean, it's just, it was quite remarkable for, I think, a bunch of reasons. But we take that information, when they set their budget, we try to, triangulate between what we're seeing in the data, what Health First sees, and what Metro Plus is also seeing. So when we're setting our rates, it's based, we have the advantage of having the information from 2 other plans. So when we do the FY25 budget, we'll take that all into account, that there will be some sort of drop. And as Megan points out, you can already start to see it. Health First, it's on a January calendar year basis, did predict a drop, but they're performing better than what they had predicted. So because the research, the Medicaid rate that the state set in April was a little bit better than they had forecasted. So I think everybody's expecting a drop. How far it drops, we'll have to see. But Health first quarter, they're doing better than budget. So.
Then this next slide is just highlighting for you some recent changes that we're seeing in the New York City insurance market. So starting in July of 2023, we've already talked about this a lot, that the Medicaid recertifications are happening, and that as people fall off of Medicaid, they might newly be qualifying for the essential plan. So we've definitely continued to see a growth in essential plan membership, which now is tied to a much richer reimbursement rate. So from a claims perspective and from a surplus perspective, we are seeing more revenue there. Next major thing that happened is that starting in January, the Medicaid managed care benefit was newly eligible for undocumented seniors over the age of 65. So that's a new coverage population that we treat many of those members, and so we're excited to see them now qualify for Medicaid. We're trying to track to see what proportion of our Medicaid population is getting this new coverage. Still too early to really be able to report back on that, but that's an exciting new development. And then just starting last month in April, the essential plan further expanded, so we call them by numbers. So there's Essential Plan 1, 2, 3, and 4. And for whatever reason, instead of saying Essential Plan 5, they decided that this new product would be Essential Plan 200 to 250. Just to be, difficult. But that does tell you who qualifies. So this is now an Essential Plan product for people making between 200 and 250% of the federal poverty level. Many of those folks had previously been eligible for coverage on the health insurance exchange called qualified health plans. And so now they can get more affordable products with Essential Plan that has very minor cost share, if any, in comparison to having significant deductibles. If you were on a bronze plan in the exchange, you'd have to pay a lot of money out of pocket to get health care. So that's really exciting. I think New York City expects maybe 200 to 250,000 people that would qualify in this bucket. So we'll see how that continues to roll out.
It will take a while, but while you're on the slide, obviously people saw that the president made it possible for people who are dreamers to qualify for, I guess it's Medicaid, because I think they already qualify for the
I think it
essential
might be this product. I thought it was maybe starting in August.
Yeah, I think so.
That the
I thought that it was, if you were a dreamer, you qualified for whatever you would have qualified for otherwise.
But now they're eligible for the,
I thought it was this new
Yeah, me
essential
too.
plan under the
we can double
1332.
check that, Mitch.
I don't, at least from the coverage, I don't think so, because this was a CMS action. So if CMS is saying, right, because we're at the moment, a DACA wouldn't qualify for anything.
Right.
So I thought that it was Medicaid.
It's still subject to CMS rules.
Yeah, yes, well, that was sort of my question, Linda, was how long, right? Because I figure that means there have to be federal rules written and
Yeah.
state plan amendment, what we were looking at and how big a population that could be of people who are using our services presumably under NYC Care currently.
Yeah, my recollection, we'll have to go back and check. I thought it was already approved, right?
I thought it was in the 1332 waiver, so
Yeah.
we'll have to
Yeah,
go back.
yeah, we'll check.
All
But
right, I
good.
mean, it's
good, it's great.
it's good news, right? It's just something to watch and to have some sense of what it will be. But I was just thinking about it because it shares in some way the process of the seniors,
Yes.
Yes.
right? They're in our system, right? And you have to get them into a different program, and presumably the same will be true for the DACA youth. You'll have to figure out how to transition them.
Exactly.
Yeah, I'll just, as we're on the
They're
topic of.
eligible to enroll in a QHP through the marketplace.
Yeah, that's it. Yes.
Well, then they're right, and I'm wrong, that it doesn't, maybe I just thought Medicaid because I saw CMS.
Right.
No, this is also subject to CMS approval, so it's like the 1332 waiver that Megan is referencing.
I
It's
got it.
all CMS.
All right, well, thanks for correcting me.
No, I appreciate it, Mitch, because I think what we don't have here, which we could have next time, is that the Biden administration did just last week or the week before release a very important regulation that's aimed at really health equity, access to services, rate transparency. It's very comprehensive, and we're just now going through the different elements of the rule. And we should come back and explain.
Yeah,
it.
it'd be interesting to get a briefing on that.
Yeah, it was very, I thought, very
Great.
nice to see them take such an active role as it relates to health equity. So.
Great, thank you. So we got 4 more minutes because
We're
my
on, okay,
chair is
no.
looking at me.
We'll be brief today.
Can we say for the HERC plan that the city pays full expenses?
We're done. Yeah.
I mean, I mean, from a finance plan, that's the answer, right? Are they continuing to pay full expenses?
Yes.
Yes.
They
What's
are.
the answer? Yes.
To the
But
question.
Ted, since you're here, do you want to give us an update on
Why
how
not?
things-
Well, actually, this is an exciting month because this is the 1-year anniversary we're coming up on for our creating the new Midtown Ellis Island or the Arrival Center at the Westwood Hotel. So we'll share more about that soon. But one of the statistics here that underlies that, which is really impressive, is we've now we put here helped over 131,000 asylum seekers at the Arrival Center alone. It's now closer to 140,000 already. So almost 140,000 people started their new dream here in New York City, or with our help, were able to get where they were trying to go within even a matter of a day or two, all through the same front door of the Arrival Center, where we screen for communicable disease. We've we've completed more than 65,000 vaccines at our sites, so we've done a tremendous amount of good at the Arrival Center. Big picture, we still oversee 14 humanitarian centers, and we currently have over 24,000 asylum seekers today in our care at those sites. When you put together the Arrival Center and the humanitarian centers, H&H has committed $1.2 billion of FERC expenses on behalf of the city through Q3 of FY24. And H&H's HERC executive funding summary is for FY24 $1.6 billion and FY25 $1.7 billion. And the last point is Mitch's point, which is OMB has provided H&H with revenue to cover committed expenses to date through the HERC MOU with the mayor's office.
Bravo.
Excellent. Any questions? Well, terrific, great work.
Thank you.
Thank you. And I guess, do we have any old business? Do we have any new business? There being no further discussion, the meeting's adjourned. Thank you.
This meeting is no longer being recorded.